is Abby. I'm a student nurse with HACC. Can I please have your name and date of birth? Suzuki sick girl, 150. Suzuki sick girl, 150. All right, great. Do you have any allergies I should know about? No? Okay, great. So today I'm going to be performing a large volume enema because you've been stating you've been having some problems eliminating. So I'm just going to go ahead and pull the curtain. So what the doctor has ordered for you today is a 1,000 milliliter large volume enema. So I'm going to be administering that. Is that okay? Yes. Okay, great. So before administering the enema, I would inspect, auscultate, and palpate my patient's abdomen. So I would inspect the stomach. Then I would auscultate in all four quadrants. So I would start lower right, upper left, lower left, and then I would palpate in each quadrant as well. So after I have inspected the bowel, or inspected the abdomen, I would don the appropriate PPE, gloves, obviously, a mask, if I felt like I needed one, a face shield, and a gown. And then I would gather my supplies. So I have a fake IV tubing, which I will use. So there are 1,000 milliliter large volume enema. So I would, tap water enema, I would obviously cross-reference that. I would make sure that was correct with the patient, with the doctor's orders, and then I would fill up my solution, and I would make sure that I had it filled with warm water. It was 1,000 milliliter warm water, not too cold, not too hot, because I didn't want to cause shock to the bowel. And then I would hang it on my IV stand in order to get ready. And then I would also instruct my patient to lay in left lateral position if they cannot tolerate Sims position. So left lateral would be on their left side, and then they would be almost like half on their stomach, half not. So their abdomen, they'd be kind of laying on their stomach like this with their head on the pillow, but their left leg would be up, or their right leg, would be up towards their chest, giving me the access that I needed to the area that I needed to work with. So I would lubricate 2 to 3 inches of my, the tip of my tubing, and then I would slowly insert this into the patient's anus at the angle of the umbilicus. And then I would use my flow on here to open gently, allowing flow with my enema, keeping a hold of it as well. And then if they told me that they were experiencing cramping, I could slow the flow here, or I would lower my solution. I would bring it down a little bit lower so it wasn't slowing as fast, because I want to make sure that it's no more than 24 inches above the patient. So I would just bring that down so it was flowing a little bit slower. And then the other things I would make sure I had before I even started my procedure would be that I had a bedpan or a commode, bedside commode, easily accessible for after the procedure. I would instruct my patient to hold the enema for at least 30 minutes, preferably as long as they could. And then I would lower my patient's bedding, give them the call bell, and instruct them to call. Very important that they call me when they felt the need that they had to go. So that's it for a large volume enema. So for changing of an ostomy, or ostomy appliance care, I'm going to pretend that this is my ostomy stoma. So this is my ostomy. My stoma is my little cup. No. Oh, my stoma is my cup, and then my wafer and my collection bag. So what I would do, so if I were to drain this, I would don gloves. Well, obviously I would do the first 5 again. I would don gloves, other appropriate PPE. I would make sure that I had a graduated cylinder or any other type of collection device. So this is my graduated cylinder. And then I would also make sure I had like a blue chuck pad or a waterproof pad underneath the bag, just to catch anything that might, just to keep the area a little bit cleaner. So what I would do is, if my bag has a zip on it, but most of them have clips, so I would undo the clip first. I take the clip off, and then I would fold the bag back like this, and then I would slowly and carefully get all of my excrement out of my ostomy bag into my graduated cylinder, document how much I have in my graduated cylinder, and then I would take a rag and I would just wipe the edge of my ostomy bag, and then fold it back up and secure it, and then make sure that just clean everything else if there was any other mess that needed to be cleaned up, and then throw the chuck pad away, don gloves, or take my gloves off, excuse me, and then I just make sure that I wanted to document how much I have in my graduated cylinder. So then if I wanted to change my ostomy bag and with the wafer with the ostomy appliance, I would empty my bag again, just so that way it was easier to work with, especially if the ostomy bag was a little bit fuller. When I take that ostomy bag off, I wouldn't want there to be in any type of way that any of the contents inside the ostomy bag would get anywhere. So I would empty the ostomy bag out first and document how much I had in my graduated cylinder. And then I would remove my ostomy bag and dispose of that. And then either with some gauze pads or with a damp rag, I would want to clean the stoma free of all of the excrement that might be present, making sure it is very clean and cleanly. And then if this is my wafer, I would take one side of the wafer and I would pull up, as I would slowly be pulling the skin away from the wafer as I was pulling the wafer off. I would inspect the skin under the wafer to make sure that it's not aggravated by the adhesive of the wafer itself, or if the hole that gets cut in the wafer was cut too big, that the area around the stoma would then be red and excoriated because of the acidic nature of the fecal matter that would be inside the ostomy bag. So I would document, make note of any of that, and then I would clean the skin as well, where the wafer was stuck to, make sure that there was no residual residue left on the stomach or the skin around that stoma hole, around the stoma, excuse me. And then I would replace my wafer first, making sure that I have the stomach itself covered while I'm cutting my new wafer in case it starts to function. Just making sure that everything is kept a little cleanlier. I would also have a guide that I would place over the stoma in order to get a more accurate sizing of the stoma the size that I would need. But I would take the stoma. We have a little hole cut already in it. It would look probably something like this. I would measure with my guide, and then I would take that over to my new wafer with a pen and draw a circle around it, and then cut out the hole for the stoma to sit inside of in my new wafer. And then I would place that over top. So I need to cut this a little bit bigger. I want to make sure that I leave enough room around the stoma opening that if the stoma were to swell while it is functioning, that it's not going to, that the wafer isn't going to squeeze around the stoma too hard. because that would cause a lot of other issues for the patient. It would cause pain, and that would not be good for the bowel that was exposed either. So the stoma, the wafer that I have cut here, well, I want to make sure that there's at least 1/8 of an inch. I cut mine a little bit bigger than what would needed, so if that would happen in real life, I'd have to start over, because I would want to make sure there wasn't a lot of skin exposed around the stoma, because like I said earlier, the acidic nature of the fecal matter inside the ostomy bag would irritate the skin. So this is a little too big, but for the sake of time, I'm not going to recut it. So I would press gently on my wafer for 30 seconds to get it to adhere to the skin. And then I would take my new bag as well, and then I would secure that to the like plastic clip around the wafer. And then I would make sure that for whatever reason that the bottom of the bag wouldn't be unclipped, that I have it secure, because I want to make sure that there's no fecal matter that's getting outside of the bag for whatever reason. I would ask my client if they were having any pain or anything like that after the procedure. And then I'd probably come back to check on them a little while later just to make sure that everything's functioning and there's not a big mess. But that is how to change an ostomy bag, ostomy appliance.